Hi, everyone. Welcome to Fits on the Go. We're covering ACC 23 live from New Orleans, Louisiana. My name is Dino Balenescu. I'm a chief medical resident at Beaumont Hospital in Royal, Michigan, and I have the distinct pleasure of talking to Dr. Barry Borlaug. Professor Borlaug is Director of Circulatory Failure in the Department of Cardiovascular Medicine at the Mayo Clinic in Rochester, Minnesota. And he also happens to be one of the world's leading authorities in HFpEF. Welcome, Dr. Borlaug. Thank you for being with us.
Thank you for having me.
I'd like to start with just a little bit of background of the RAPID-HF trial. So HFpEF is an extremely heterogeneous condition, which means that there's no one-size-fits-all approach to its management. And until very recently, with the rise of the SGLT2 inhibitors, we didn't really have any kind of treatment to improve outcomes in HFpEF. So how do you even think about addressing treatments for HFpEF? Well, one way to look at it is to think about ways to counteract pathophysiologic mechanisms in HFpEF. And one such pathophysiologic mechanism is chronotropic incompetence. So, Dr. Borlaug, what is chronotropic incompetence in HFpEF, and how is this concept addressed in the RAPID-HF trial?
Well, it's true that HFpEF is heterogeneous, but there are certain overarching findings that are present in all patients, such as elevation in filling pressures at rest or exercise. And one of the most consistent findings is chronotropic incompetence. In cross-sectional studies, there's a very tight correlation between how much your heart rate increases with exercise and your overall exercise capacity. And that's been consistently shown in patients with HFpEF over the years. We also know that well over 50%, the estimates depend on the study that you look at, but certainly over 50% of patients with HFpEF meet the definition of chronotropic incompetence. The most often used clinical definition is abnormal heart rate reserve. Heart rate reserve is calculated as peak heart rate minus resting heart rate divided by age predicted peak heart rate minus resting heart rate. And if that is less than 80% or 0.8, that's chronotropic incompetence. Now, if you're on a beta blocker, you set the bar lower, obviously, because you expect some chronotropic incompetence there. So if they're on a beta blocker, values less than 0.62 are diagnostic of chronotropic incompetence.
Thank you for that, Dr. Borlaug. And enter RAPID-HF. So what was the idea for the study? What were the main methods used, and what did the study population look like?
Well, we've known for years that chronotropic incompetence is very common in HFpEF, but no one's really known what to do about it. So this was a trial where we took patients with HFpEF who had clear-cut chronotropic incompetence, and they underwent pacemaker implantation with a dual chamber rate responsive pacemaker set not to increase the resting heart rate, but to increase the heart rate with activity. With the idea being if you have more heart rate, you're going to have more cardiac output, you're going to have better exercise capacity and improved quality of life. Because everybody had to get a pacemaker as part of this, it's a crossover trial. So in one phase of the trial, after everybody gets a pacemaker, and in one phase, patients have rate responsive atrial pacing set on for 4 weeks' time. And then they have a cardiopulmonary exercise test at the end of that 4 weeks. And then then there's a 4-week washout period, and then they cross over to the other side. So if they had pacing on first, they get no pacing, and vice versa. And then after 4 weeks of the opposite assignment, then they get another cardiopulmonary exercise test. And you compare the results of those two exercise tests. And because each patient is their own control, it's a very rigorous and sensitive technique.
That's quite the smart study design right there. Now, a little bit about the device used. Now, number one, did these patients have any kind of other indication for a pacemaker device? And number two, is there anything special about the device you used as part of addressing chronotropic incompetence in these patients?
No, this is a pretty standard pacemaker made by Medtronic. It's MRI compatible. Nothing really very special about that. And I forget what this other part of your question was.
If these patients had any other kind of indication for a pacemaker, or it was purely for HFpEF?
No. No, that's actually one of the exclusion criteria. So if you had an established indication for pacing, you wouldn't get it. You wouldn't be involved.
Understood. And now, since you addressed the exclusion criteria, what were some of the inclusion and exclusion criteria for this study?
Well, we included patients with heart failure and EF of 40% or greater. Now, what we ended up recruiting were all 50% or greater, but in order to have a wider reach in terms of patient eligibility, we actually included 40% or higher. They had to meet clinical criteria for HFpEF, which is one of several ways. You could have had a prior heart failure hospitalization, you could have invasive hemodynamic testing, you could have an elevated NT-proBNP, or you could have marked diastolic dysfunction on echo with treatment with a loop diuretic. So these are all very accepted indication or diagnostic criteria for HFpEF. And we excluded, as I said, patients with other indications for a pacemaker or patients with atrial fibrillation, because that obviously changes a great deal. And we also excluded other, rare causes of the clinical syndrome of heart failure with normal EF. So specifically like restrictive cardiomyopathies or amyloid or constrictive pericarditis, things of that nature.
So, a very targeted population.
Yeah, we're going after basic garden variety real HFpEF, but not some of the zebras like typical HFpEF patients.
Understood. So, what were some of the main results of the rapid HF trial?
Well, we saw that in the pacing off phase, there was a significant association between exercise heart rate and exercise capacity measured by peak VO2, peak oxygen consumption, and also the oxygen consumption at anaerobic threshold. And that's consistent with what's been previously reported. So having a higher heart rate is clearly associated with better exercise capacity. We also saw that with pacing on, there was a very significant increase in heart rate during low-level exercise and maximal exercise. But despite the fact that heart rate went up and that heart rate was associated with exercise capacity, when you increase it with a pacemaker, we see no improvement in exercise capacity, whether it's measured as oxygen consumption at anaerobic threshold or peak VO2. There was no benefit associated with pacing on versus pacing off. We then did some mechanistic analyses, and I'm very glad we programmed this in. This was all non-invasive, this study, and there is a technique of inert gas rebreathing. So patients breathe in acetylene gas, which is soluble in blood. So essentially, if you measure this and look at the disappearance rate of acetylene in the expired air after a patient breathes in acetylene, you can measure what their cardiac output is, and you can do this at rest and exercise. And even though heart rate went up substantially with pacing, there was no improvement in cardiac output. And of course, cardiac output is equal to stroke volume times heart rate. So that means that there was a reduction in stroke volume with pacing. So I think that's why it did not work. That would be the most likely explanation, is that despite the fact that the heart rate went up, this was counterbalanced by a reduction in stroke volume.
Understood. So basically, the jury is still out on directly addressing chronotropic incompetence as a mechanism in HFpEF.
I don't know if I'd say the jury is out. I think that what this study shows is that giving somebody a pacemaker and programming it for rate adaptive pacing does not appear to improve exercise capacity. And this has been recommended in guidelines with no evidence for years because it makes sense that it should work. But our data suggests that it doesn't work. So we probably, based on this data, we probably should not be implanting pacemakers for this purpose. Might be better doing other things like withdrawing beta blockers or AV nodal blockers or something like that to improve heart rate responses, unless there's an absolute indication that patients should be on those.
So in this scenario, what's next for the invasive management of HFpEF?
Well, yeah, I think I'm less enthused about pursuing pacing. As I mentioned, beta blockers are still heavily used in patients with HFpEF with very little to no good evidence to support it. They clearly are excellent medicines in heart failure with reduced ejection fraction, but there's really not good compelling indication in HFpEF. So I'm taking a lot of my patients off beta blockers. And I think that can definitely improve exercise tolerance. These people have cardiac output reserve limitations. They have a blunted stroke volume response to exercise, and a lot of times heart rate is the last thing they have. So you want them to have more heart rate. But our study shows that achieving that with a pacemaker does not translate or result in a clinical benefit in exercise capacity.
It's an absolutely excellent addition to the literature. And Dr. Borlaug, we can't possibly let you go without asking our favorite question of the interview. Namely, all of us are trainees. What advice do you have for trainees interested in HFpEF?
Well, I think it's all about knowing the literature, reading about it, being curious, and being determined. I think that there's a lot of frontiers in the field of HFpEF, and a lot of observations that we make at the bedside or in the clinic, where you just ask the question, why is this? Those are the things that really ultimately lead to pathophysiological studies and then later clinical trials, even early phase clinical trials, mechanistic trials like this one, where you can then develop a hypothesis and really test it. But it all has to start from the bedside in the clinic. And I think, you're right now in training, that's what you're seeing all the time. So just keep coming back to and thinking about, what are the key questions? Do we really know the answer for this or not? And at the same time, keep reading your journals and everything, because scholarship is very important. You have to understand the literature in order to understand what the next best questions are. But I think that everyone that does these things, you can really have great potential careers in academic medicine.
That's excellent advice. Thank you so much, Dr. Borlaug, for going over the Rapid HF trial with us. For more Fits on the Go coverage from ACC 23, please follow our Twitter page at Fits on the Go and check out our YouTube channel for full-length interviews at youtube.com/fitsonthego.